Hello, everybody. Welcome to another episode of Pod Isa. I am Isabela Castro, your host. And guess what? Today we have an extraordinary guest, Professor Jason Leitch, former Scotland's National Clinical Director, as his accents always said, and a leading voice in global public health and healthcare improvement. Dr. Leitch has played a pivotal role in Scotland's response to COVID-19, patient safety, and healthcare transformation. Welcome, Jason.
Thank you, and thank you for having me. It's a great pleasure to be here and talk to both you and those who will be unfortunate to have to listen to me if they click on the button. I've just worked out. I hadn't worked out until this moment, until you said it out loud, what Pod Isa is. It's Pod Isabela. I hadn't.
Oh yeah.
I hadn't worked it out. It's very clever. So I'm delighted to be your guest. Thank you for having me.
Oh, you are very kind. Yesterday I sent an email to Professor Jason Leitch asking him, "Are you happy to share your brief bio?" But he sent me something else, and I'm gonna share with you. You'll be amazed just as I did. Jason is a senior fellow at the Institute for Healthcare Improvement. From January 2015 to May 2024, Dr. Leitch was the National Clinical Director for the Scottish Government. He worked for the government from 2007 as the National Clinical Lead for Safety and subsequently for Quality. The National Clinical Director is responsible for quality in the health and social care system, including patient safety and person-centered care, NHS planning, and implementing quality improvement methods across all the country, the government, and the broader public sector. He was appointed CBE, in the 2019 Queen's Birthday Honors. He was elected to the U.S. National Academy of Medicine in 2022, a rare accolade for a non-U.S. citizen. Too. He's an honorary professor at the University of Dundee and a visiting professor at the University of Strathclyde, in Glasgow. He was a 2005-06 Quality Improvement Fellow at IHI in Boston. He's a non-executive board member of the Medical and Dental Defence Union of Scotland, a board member of the Nazareth Trust, which runs an acute hospital providing care in northern Israel and the West Bank, and a trustee of the India Rural Evangelical Fellowship, UK, which runs a children's home and schools in Southeast India. This is my favorite. He qualified as a dentist. He also happens to be a dentist by profession in 1991 and was a clinical academic and consultant oral surgeon in Glasgow. He was a doctorate from the University of Glasgow, a master's in public health from Harvard, and is a fellow of the 3 UK Surgeon Royal Colleges. He is an international recognized speaker and advisor on health and care improvement, public health, and has advised countries all over the world. While I was reading this bio, I was thinking to myself, what are you doing here?
Well, I came because you asked me, and the bio is mostly boring. The only two really interesting things are actually the two charities. The one in Israel, serving the Arab-Israeli population in the north, which has been a very big challenge for them more recently, and the Indian charity. They are the only two interesting things. Everything else is very conventional for a man of my age, I think.
Well, Jason, it's a super honor to have you here speaking to our Brazilian audience and some international ones. Thank you so much for accepting. I am feeling the plebeian here, so it's a honor to have you. So let's start with a conversation about health quality and system improvement, as you've led a super and radical transformation in healthcare in Scotland. Your work with the Scottish Patient and Safety Program has been widely recognized. I've been following you since we met in Mexico, 2016. Paulo Boré introduced me to you, and I've been following you, and I've been to Scotland to shadow the What Matters to You movement. Another thing that you've spoken in a TED talk, and there was a super transformation in healthcare in terms of quality and improvement and patient participation. Can you share some of the biggest lessons learned in improving healthcare quality in a national scale?
Yeah, so let's just go back to the diagnosis before we do the treatment. Perhaps you're very generous and kind. I was a small part of a massive machine, a small cog, perhaps in the middle somehow because I was in the centre of the government. But we had a very, very bad safety event in Scotland in the mid-2000s where around 30 older people died in a hospital not far from here, actually, in Glasgow, where I am just now. And they died of Clostridium difficile. They died of a disease which we gave them when they came to hospital, not a disease they had when they arrived at hospital. It was a big scandal across all the newspapers, and there was a lot of work involved in working out what had happened. Long story short, the government, the Scottish government, remember, different health service from England, so we have our own health service. It's very similar to the English system, but we run it, we fund it. It comes from the Scottish Parliament. The Scottish government decided to try and do something about that, and I was fortunate enough to have just come home from IHI in Boston, the Institute for Healthcare Improvement, probably the global leader in healthcare change and improvement at IHI. And I was randomly there doing a fellowship, came home, got a job helping with patient safety. So we then, for a decade, I'm having to shrink the story, we then for 10 years tackled patient safety in our 21 acute hospitals. We're not Brazil. We're 5.5 million people. We're about 800 miles from top to bottom and about 300 miles from side to side. We've got some islands with rural communities, and we've got a lot of people who live in 4 main cities. So we don't have your geography. And the times I've been to Brazil to describe this story, I'm always struck by the scale of what you guys are trying to tackle. So we're like a state in Brazil, not a country. However, we've still got 5.5 million people in 21 big hospitals. So we ran a safety program across all of them, doing 4 main things: intensive care, wards, theatres, and medicines. So four big strands of work, doing all the things you would expect if you followed the safety movements around the world. Critical care bundles, medicines management, theatre checklists, all the things you would expect. And we reduced mortality by about 20% in our hospitals. And we reduced surgical mortality by about a third. And we reduced infections by 95%. So we got rid of Clostridium difficile. We got rid of a lot of MRSA. Now, your question was actually lessons from how we did that. So there's loads. But let me limit it to 3. Lesson number 1 is you require leaders. You need leadership. Now, that leadership could be inside a ward or inside a pharmacy. In my world, we required government leadership. You couldn't do it in Scotland without the minister in charge of health saying this is what we're going to do. But you also needed clinicians, civil servants, chief executives, doctors, dentists, nurses. The whole team had to lead. The second lesson is you need to count. You need to have data. Otherwise, nobody's going to believe you. You're not going to know if you've got better. So one of IHI's main lessons is to try and have data and a graph and stuff that you can talk to the press about and talk to the staff about and the patients and families about. And my third lesson is that all improvement is local. All improvement is local. So although you set the vision centrally, so we said we're going to reduce harm by 30%, we're going to reduce mortality by 20%, we're going to do this together. That was announced in the Parliament by the Health Secretary. I mean, it's a big deal. The actual change that needs to happen is in an intensive care unit with 1 patient and 1 nurse, or in a dental practice with 1 patient and 1 dentist or 1 therapist, or wherever that interaction takes place. So all improvement actually has to happen in that tiny microsystem, what we would call the microsystem in improvement jargon. And you have to try and link those two things. So that was our main task for all of those years, to try and make sure the people in the front line knew what to do and how to make it better. And that's what we did. And when I talk about the safety program to other countries, like in Denmark, where they've done a very similar piece of work, they've done similar bits of work across America and across the world. Those are the things I tell them. Make sure you have leaders, make sure you have data, and make sure you allow the front line to do the work.
Well, it's a great approach, and I saw that you've had to, in parallel, some teaching programs. Some of them in partnership with IHI, and others that were led by the government. I remember I was almost enrolled in one of them. It was a fellowship program.
So we've tried to, and this might be lesson number 4. We've tried to build capacity. So we've tried to build capacity inside the system to know how to do change. You don't naturally know how to do change just because you're a cardiologist or because you're a pharmacist or because you're a physiotherapist. You have to learn how to do change. There is a science behind how to do change, and lots of people know it, but most of them are outside healthcare. They're in engineering, or they're in systems redesign of factories, but there is a science. And that science is what IHI have adapted to use in human systems. It's about microsystem change. It's about having the data. It's about testing in the real workplace. So we teach that. And initially we taught it with IHI. So in 2007 to 2017, probably for about 10 years, we taught alongside IHI. They would come, we would put people on the course. Now, the Scottish version does it itself, and we sell it a bit to the world. So we have occasional Canadians or Danish or even Brazilians who come and they take advantage of that Scottish training, but it's mainly for Scottish people. And we try and teach them then how to do change. So we teach them the models, the frameworks, they do a project, they get to know each other, they get a peer group. It's kind of what I did in America when I was with IHI. And you end up with a group of people who you're on this mission with together. It creates community. And that still goes on. We have the Scottish Quality and Safety Fellowship, we call it now, for clinicians. And then we have another one called the Scottish Improvement Leaders Programme, which is for clinicians and non-clinicians. So we have teachers and prison officers and police officers and civil servants on that one. So it's a much broader group of individuals. You'll notice that all we do in Scotland is we just put Scotland in front of everything. So we do the Scottish Fellowship, the Scottish Improvement Leaders Programme, so to make sure people know that it's us.
I love it. So if you had to, you've mentioned 4, but like in your heart, if you had you that was there leading and living that moment of, revolution and changing, if you had to choose one, this was the most important of them. I know this is an unusual question because we usually don't have one thing, but if there is one more special for you, like people or system changing or what would you pick?
I think the most important lesson, and the thing we get wrong most often, is we try and impose change from the top down. So the most important lesson is that change happens from the bottom up. But you still have to manage that change. So that's why you need senior leaders to be involved too. You can't do it. One is not possible without the other. But my whole career, I've had letters from government telling me how to do a thing or do the guidelines, or that doesn't work. What works is combining top-down vision and aim with bottom-up change and improvement. So I think that's where we get it wrong most often around the world. And I think that's what the Scottish Patient Safety Programme proves, that if you do it from the bottom up, you can actually save lives.
Yeah. And when I've been there and I saw how people, they are really engaged. I was in a meeting in the What Matters to You Day, and people are really engaged. We were in tables, that was awesome how people really participated. And they were not just people in leadership positions. Most of them were frontline workers.
Yep.
It's an awesome job. Congratulations. But moving to public health communication and trust, maybe some of the Brazilian audience doesn't know, but during the COVID-19 pandemic, you became one of Scotland's most recognized public health figures. What were the biggest challenges in communicating health advice to the public, and what strategies proved most effective?
Well, you're kind. I was one of a number of senior clinicians that our politicians decided should be very prominent on TV and radio, and we did daily press conferences 7 days a week for months and months. And then we did lots of radio and TV shows and in Scotland, like Brazil, the thing that Scotland and Brazil have in common is football. We have a love of football in both countries. So every Saturday there is a football show on Scottish radio that is very, very popular. But there was, of course, no football because football had closed down. So I was on the football show every week for months. And it is still the thing that most people come up to me in the street and say they remember. It's called Off the Ball, the show. And it usually does a phone-in show about football, but it became a phone-in show about COVID. So I would answer questions from the public. And so I did become, unfortunately, quite well known in Scotland, and people still talked. Just yesterday, a lovely gentleman came up and thanked me for my work. So you asked about what was the hardest. That the hardest thing was the constantly changing picture of what we knew. So the nature of an emergency pandemic and the speed at which the science was trying to catch up with reality was probably the hardest thing that we had to communicate. I mean, the hardest thing personally is the long hours and the hard work and all. But the hardest bit about the challenge was that on a Monday morning, you might have virus A, and on Wednesday morning, you might have an entirely different virus that is now behaving very differently, and you've got to give different advice. So leading up to Christmas 2020, it looked as though we were going to be able to open up a bit for Christmas because it looked as though the virus was being quite well managed. It was suppressed. We were going to allow families to meet. And then we got a new variant from South Africa, and it just suddenly appeared, and it was worse. So then we had to go back on TV and say, we know we told you yesterday you could have Christmas. Now the advice is not to have Christmas in the way. So then you get, I was the Grinch on the front page of the newspapers. So the front page of the Scottish newspapers superimposed my face on a picture of the Grinch because I had cancelled Christmas. So the hardest thing I think for the public and for us to try and communicate was the way the virus was changing, and therefore the way the science was changing. Because it's hard for people to understand that science is live. Science is not a fixed thing. I mean, scientists used to believe the world was flat. The world isn't flat. The world is round. So you have to change what science teaches you over a period of time.
Yeah, sure. I remember we had the same crash in Brazil, but in a very negative way, because we had a lot of instability in terms of acceptance of the science. There was a lot of people not accepting immunization. Did it happen in Scotland? I don't think so.
So we had some of it. We had particularly vaccines. We didn't have much of the full-on global conspiracy that COVID was made up and COVID was not real and COVID had been designed. We didn't have much of that. I mean, a little, but nothing significant. But when you create a new vaccine around the world very quickly and it looks as though it's going to save the world, there is of course some skepticism about the speed of development, the safety of development, all of those things. So we had three groups. We had the groups who were non-questioned, just very willing to do and accept the science which we gave them. And then at the far end, there was a small group of vaccine skeptics who thought it was unsafe, who didn't believe us. And then there's a significant group who just wanted more answers. They just wanted to know, how had it been done so quickly? Where did the money come from? What companies had... And that's okay. So we spent a lot of time with them. And some of them are in communities around Scotland whose language isn't English, who are immigrant communities, who are different ethnicities, who are getting their news from different sources. So we tried as far as we could to go on Polish radio, we have an African radio station in Scotland that speaks to the African immigrant population. So we tried to go and tell the truth in each of these settings, and it worked. So we got very, very, very high compliance rates with vaccination, and we were able then to open the country relatively well because of those high vaccination rates. We got into the high 90s in the over 65s in particular. So we had very, very good vaccination rates.
That's great. Well, you became famous. Now, a dentist, a dental surgeon, and then goes to Boston, spends a year at IHI, and then you're back to Scotland. You suddenly have a scandal in healthcare, and then you lead a quality improvement project, and then you lead the national strategy, and boom, you were on TV leading COVID-19 strategy and talking to the entire communication of the country. So moving to leadership crisis and decision making. You have advised the Scottish government on a major health decisions. And as you just said, things were changing very, very rapidly. What are the key leadership traits need to navigate on crisis effectively?
Yeah, that's a big question. People have written books on the answer to that question. My lessons would be about not realizing you can't do it all. You can't have all the knowledge. You in fact, you might have very little of the knowledge. So you need a series of experts who can help you. For example, I have a public health degree, but I'm not a public health professional. I don't do public health for a living. I was a surgeon. So I have some public health knowledge, but nobody has all of the virology knowledge, the vaccination knowledge, nobody. So you need an advisory group to be able to help you with that. So we had deep public health knowledge in our community. We had very good immunology knowledge, very good behavioral science knowledge, very good communications knowledge. So the ability of a leader, whether it's the political elected leader or the clinical leaders, the chief medical officer and I had to gather those experts together and try and find a consensus view that would guide us through what was an unprecedented challenge. Probably the best example is behavioral science. Apart from all of the public health science and the virus science, we needed to be able to change behavior in society. So if we're going to tell everybody to stay in their homes or not go to restaurants or not go to the football, whatever it was, we needed behavioral scientists to help us with the messaging. And I remember him telling us he was a wonderful human being, and he wasn't a doctor, wasn't a dentist, he wasn't a clinician, he was a behavioral scientist. He understood the science of human behavior, and he said, if you explain the why before the what, people will do it. So don't just go on TV and say you can't meet your family or you can only have 2 people around for dinner. But he said you have to tell them why. So you have to explain that there is a new variant. That new variant is spreading faster than the last one. That is X, Y, whatever. Then, and your way of helping us is to only have 2 people around for dinner, to stay at home as much as you can, to not send your kids to school because we're going to close the school, all of that. So he was a great help. And now I don't have that background. I not everybody can have every background. So the key leadership trait, I think, is understanding you have to seek advice and help from other spaces. And our First Minister, so our leader, our political leader at the time, was very good at gathering information from different people. And then there was a small room of people who gave the final advice to her, and then she and her cabinet would then decide on what they were going to do for Scotland. The other key lesson, of course, is to be very clear that you're not a decision maker, you're an advisor. The decision makers are the people who were elected to make the decisions. Now, you might not like that, but that's the nature of democracy.
Yeah.
So that's who you have in charge, and the advisors advise, the decision makers decide. So I was very careful, or as careful as I could be, to draw that distinction as much as I could.
Lovely. So you had to balance between science, policy, public perception. At the same time, you were not in a political position, and at the same time, you had to be on TV advising people. But you agree that you are a good communicator, don't you?
Well, yeah, others would have to judge. Now, I don't think everybody thinks I'm a good communicator. Some people think I'm just.
I think you are.
Some people think I'm annoying because I closed their schools or I closed their soft play. But I've learned over a long career, too long, that telling the truth with story and narrative before you use data, and maybe with if it's an appropriate moment, with a sense of humour, worked for the Scottish people. But there were times when it wasn't funny. I mean, it's not funny when people are dying and the disease is ravaging the country and the world. So it wasn't always appropriate to be flippant, which is my natural habitat, is to be flippant and try and be funny all the time. So you have to adapt to the audience you're with or the crowd you're with, and adapt to whether it's children you're speaking to, or we spoke to Scotland's young people a lot. We spoke to the people who own Scotland's restaurants, the people who own Scotland's football teams. You know, you have to adjust. So I tried always to tell the truth as much as I knew it in the moment when the truth was there, and I tried to do that with, let's call it, a humanity. So I tried to do it with humanity, and most people seem to think that worked. And then we had other people communicating too. So we had the senior politicians, we had the senior public health advisors, I'm sure Brazil had a combination of people who were trying to tell the country what to do.
Yeah, sure. Well, looking ahead, we've spoken about a little bit about your history, your journey, a little bit about the past. But now looking ahead, thinking about innovation and all this, innovation, artificial intelligence, innovation or trends, do you believe will shape the future of healthcare systems worldwide? Any ideas on that? Any comments, thoughts?
Yeah, you've opened the door immediately to digital and AI. I think I'm not quite sure we understand what that's going to mean. I know for sure that AI will start taking notes for us. It will start reading mammograms for us. It will start reading CT scans for us. I think we can take all of that for granted now. That will come, and it will be better because it is better at finding cancer than the human eye. And the best is to combine the technology to help us with dermatology, with whatever. I mean, since I qualified, you can now scan a mouth with a camera and get a 3D image of that mouth, see what the teeth are doing. I mean, that was unthinkable when I was training, that you would have a machine that could make the filling outside the mouth, and then you could put that filling in the mouth. I mean, that's science. It sounds like science fiction when I was training, although it was a long time ago. So I think technology will come. I think the big challenge is that we don't know how to stop demand. So all the work we do just now is on the supply side. Build hospitals, make doctors, make dentists, create more physiotherapists, make better drugs, make better scanners, all of that. And that's good. We should do that. We should do as much of that as we can. The difficulty is that the actual problem with the health of the world in Scotland and Brazil, in anywhere, is the demand. So unless we slow the demand down, we're going to have to keep building more supply. And the numbers in Scotland suggest that in the next 20 years, our demand is going to increase by 21%. So if demand goes up by 21%, you need 21% more supply.
Yeah, sure.
No country in the world can afford that. It's impossible. And Brazil will be very similar. As your country ages, as you get better at keeping people alive from cancer, from heart disease, that's wonderful. We should celebrate that the population is getting older and will live longer. That's a joy. But if we don't stop the demand for disease reduction, we're stuck. So I don't know where that comes from. It's very boring. It's good sleep, good eating, good exercise, good sexual health, it's all these elements that we know about, but it's very, very hard to do in a society. Other countries are trying. Singapore is a very good example. Yeah. Japan is quite a good example. And Scotland is trying. We've done smoking cessation. We have a big problem with alcohol. We've done minimum unit pricing of alcohol, which has helped reduce our alcohol intake. So there are little bits, but how do we make all the children in Scotland fitter and healthier and all of that? So I think that's the trend that has to come. And I think that's the next big challenge for the generation that you are, as my generation gives you the baton.
Almost in your generation too. If you could implement one major healthcare reform globally, what would it be? That is tricky.
That is tricky. I think it depends where you are, probably to some extent. If you'll allow me clean water, access to vaccines, and access to primary healthcare for the world, I think they're the most important things altogether. So if you look at the WHO's priority list, then they have different words for it, but they call it universal healthcare. So what it means is the basics are available in West Central Africa, rural India, Palestine and Israel, Scotland and Brazil. So let's say we're going to have that first. That would be the most important thing. I think if all of that is in place, which it isn't, of course, but let's say we get all of that in place, I think then it's about the health of the children. I think it's about the only way of dealing with the demand side is to make kids healthier and give them healthy lifestyles as they grow. So less fast food, less sugar, more exercise, better sleep, better habits, all of that. So I think implementing health interventions for children is probably where we should put most of our energy and most of our money.
Yeah, to shape a better future, this would be a gold standard.
Because my age, my generation is done. I'm going to get chronic disease, whether I like it or not. It's too late.
Come on, Jason. Well, unfortunately, we are getting to a close. I wish we had more time to chat. It's always a pleasure to chat with you, and always a honor. We don't have a chance to be with Jason Leitch every day. So, Dr. Leitch, it has been an absolute honor to have you on the Pod Easy today. Your insights and your company are invaluable. So I'm happy to share your social media in case your audience want to follow your work and stay connected. You want to share with us some last thoughts, one last thing, one last advice to our audience?
Yeah, I think so. I've backed away from social media a little bit, partly because of my COVID profile. It was getting it was on occasions a little bit heated. So I think I'll return, but I'm keeping a slightly lower profile than I was. I think my advice goes back to something we said earlier about change, and even this week when you watch the news or think about what's happening in the world, it can feel completely overwhelming. You feel as though maybe I should just stay in bed with the duvet over my head. It would be easier. The reality is there are things you can change in your microsystem, whether you're a nurse, a dental nurse, intensive care doctor, a manager, it doesn't matter. There are things you can make better in your environment. And sometimes when we look beyond our environment, it can become so complex that we get crippled by the complexity. The reality is just make it better tomorrow. And you gave a very good example of that with your reference to the What Matters to You movement. The What Matters to You movement is at one level very simplistic, and at another level hugely powerful, because it is simply a desire to ask patients, families and carers, or even co-workers, what matters to you, not what's the matter with you, not that you've got a wisdom tooth that needs to come out, or you've got a heart attack that you've had, or whatever it is. You've got something that is about you. So what matters to you? Well, what matters to me is my family, my football team, my dinner, my coffee, my whatever. I also happen to have asthma, diabetes, I've had a heart attack, I need my whatever. So that individual little conversation just adds humanity to healthcare. So I think we can sometimes lose sight of the fact that in the next interaction we have in our clinic or in the boardroom or wherever we're working, it might just be transformed by something we do.
Sure. May you allow me to tell a little story? I went to IHI in 2016. I remember because we were in the Olympics in Rio. I enrolled in a course. What's the name of that course? Summer immersion course. It was a one-week course. I think it was in July. And the president at that time was Derek Philly.
Yep, another Scotsman.
Yeah, it was Scottish with that accent too. And I was a dentist. I was convinced that I didn't want to live in a dental office. I want to do something. At that time, I knew that the system had to change, but I had no idea how. And I stayed 1 week in IHI. They presented projects around the world and nothing in dental care. And then finally on Friday, in the final day, he asked, does someone have any questions? And I was the first one to raise my hand and said, you don't have anything in dental care. How do you say that you are leading dental health transformation in the world? And then he was like, I'm going to give you an email of a senior fellow of ours who is a dentist. His name is Jason. Write him. And he's leading a super transformation in Scotland. He's super. But then I kept that paper, like I put it in my backpack. I came back to Brazil and I thought, this guy will never answer me back. And I completely forgot about it. But weeks later, maybe months later, I was organizing stuff. And then I opened my backpack and I saw that paper and I was like, why not? And then I wrote an email to Jason. And guess what? 1 hour later,
he didn't answer.
He answered me. He answered me like with this enthusiasm. I'm so glad to hear from another dentist, blah, blah, blah. Isabela, I'm so happy you connected. So Jason is that kind of person. He's so humble, so generous, so lovely. This is not for you to see in the camera. He's not pretending to be lovely. Jason is as lovely as I'm telling you that he is. So Jason.
Well, that's a lovely story, Derek. I'm seeing Derek for dinner on Saturday, so I will tell him that he's now retired and back living in Scotland, and we're still friends. So I'm having in his son's new restaurant. His son has just opened a new restaurant in Glasgow. A new small restaurant, but it's a hard business to make a living in. So we're going to his son's restaurant on
Oh, that's nice. Please send him a hug and please tell him that he did make a difference. He made a difference when he introduced you to me.
Well, that's fine.
Yeah, we've been in touch. Yeah. So thank you so much, everybody, for joining us. And to our listener, if you enjoyed this conversation, don't forget to share and keep the discussion going. See you next time. Bye. Jason, thank you so much.